Improving patient outcomes will demand that the healthcare system develop innovative strategies that refocus the system on teamwork, coordinated care, and a reduction in adverse health behaviors. Perhaps no one is more qualified to address how this reform should occur than our next speaker. Dr. Atul Gawande is a general and endocrine surgeon at Brigham and Women's Hospital in Boston, who has a practitioner's grasp of the everyday challenges of healthcare delivery. He is an accomplished author whose 3 books and numerous columns for The New Yorker have been highly praised for their insightful and visionary ideas. He is a MacArthur Genius Fellowship grant winner, and Time magazine has placed him among the world's 100 most influential thinkers. Dr. Gawande has revolutionized the provision of complex workflows in the hospital through the use of checklists and developed creative concepts for increasing quality and efficiency while reining in healthcare cost. We are absolutely honored to have him with us today as he shares his wisdom in his presentation, The Century of the System. Dr. Gawande.
I'm extremely honored to be here. Thank you for inviting me, helping me be a part of your conference. I have no relevant financial disclosures to make, except that I was supported for more than 18 years of my life by a pediatrician, my mother, who was a more than 40-year member of this organization. When I told my mom I was getting to talk to you, she was so proud. She came to every conference, but she never took me. My dad and my mom would come, they'd travel to wherever it was, they'd get rid of us, and then they would come to learn. My mother was from India, my father's from India. They met in New York City. My mother was a resident in Brooklyn, and I was born while she was chief resident. And it was a different, simpler time. So as chief resident, first of all, it was a more complex time. She had to go back to work after about 2.5 weeks. But it was also a simpler time because since she was chief resident, she assigned me to be in the nursery. And the intern literally would have to round every day on me. Later, she and my father, we all moved to a small town in Ohio, Athens, Ohio, southeastern Ohio. How many of you are from Ohio here? All right, Ohio. Well, in southeastern Ohio, there was just 3 pediatricians in a community of about 50 folks. And I got to tell you, she has always regarded this organization and this meeting as her lifeline. It was the place in the 1970s and the 1980s where she could learn and understand how to bring what was changing so rapidly that what she had learned in residency was becoming irrelevant as time went on. And it was the place she could figure out how to bring that into her practice in a small town in Ohio. There came a point, though, where it became overwhelmingly complex. And as I was sitting getting to listen to this morning's meetings, I could imagine how it must feel for those of you trying to do this work. How to incorporate everything from what to do about the genetic conditions of cardiac illness to how to manage the post-cancer survivor to what to do about the kids with traumatic injury and issue, traumatic damage that they've had to witness or receive themselves. And what she ended up finding was that she simply couldn't do it all. She made a focus on her office, but began trimming back how much she saw anybody in the hospital, and then more or less transferring anybody who required more than 2 days in the hospital up to Nationwide Children's up in Columbus, which was about 80 miles away from where we lived. And what it brought home to me, talking with her over the years as I got to become a physician myself, went into surgery, was this key puzzle, this key problem in healthcare that I think is the root of our great difficulties. It's the root of our troubles of cost. It's the root of the battles over government regulation versus whether there's too much business in medicine. All of these are symptoms of the larger problem, which is the extreme complexity of what the discoveries of the 20th century and now the early part of the 21st century have given us. Capabilities that involve being able to diagnose and classify more than 13,600 different ways the human body can fail. How do I know it's 13,600, you ask? Pick up your ICD-9 codebook and count how many diagnoses are in that book. And that's the range of what we classify. By the way, when ICD-10 comes out, it's 66,000. And we've discovered more than 4,000 medical and surgical procedures, more than 6,000 drugs that can make people better, that can reduce their suffering, that can, if not cure them of every condition, can help them. And our job has become trying to deploy that capability town by town to every person alive. This is an awesome job, but an extraordinary responsibility. And isn't any surprise that we have a hard time trying to deliver on it? The puzzle we're struggling with is how are we supposed to handle all this complexity? Now, one of the analogies that you have often heard is the idea that, well, in many other industries, they have learned to handle complexity, whether it's putting up skyscrapers or flying airplanes in every part of the world. They've learned to make it so that practitioners could have extraordinary capabilities. And many of these fields are not just like medicine, but they have learned something. And so in the course of some of the work that I've gotten to be part of, we did some research trying to understand, well, what happens in these other fields? And what I came to realize is I was interested in not what happens in these other fields, but when did they change? When did they go from being kind of a mess and really hard to manage to actually becoming something that felt manageable under the conditions of all that complexity? And one of those examples is the aviation industry. And we see all the things that they have today to make things work, from complex technologies on airplanes and investigations of crashes and feedback loops and so on. But there was a moment when that world changed. And that moment was when this plane got built, the Boeing Model 299. It was an airplane that was designed when the US Army wanted a new long-range bomber to be designed for them after World War I. And so they put out a request for proposals, and multiple airplane companies ended up sending them designs, but this was the one that they salivated over. Because planes to that point had been built with one engine or two engines on it, and this one had 4 engines, 2 on each wing, and that meant it could fly higher, farther, faster, with 5 times the payload of any previous airplane. It was a beautiful thing. It had this silver gleaming skin on it, and when they rolled it out, they thought, this is our plane. And so they had a flight competition where everybody brought their models out and to show the generals, but they knew this was the one that they were planning. In fact, they already had plans underway to order a little over 200 of them. Boeing was gearing up. They therefore watched it going down the runway, seeing the future take off for them. They watched the plane lift off into the sky and then crash to the ground, killing the crew on board. There was an investigation. It showed there was no mechanical fault of the airplane. Instead, it was pilot error. When they dug a little deeper, what they found was that putting 4 engines on the plane made it a much more complex thing to fly. You had to monitor the fuel mix of each of the engines, adjust the propeller pitch of each of them. There were electronic trim tabs that controlled the surfaces of the wings that you had to set, the retractable landing gear, et cetera, et cetera, et cetera, et cetera. And the pilot had gotten it all right except for one thing. There was a lock on the elevator controls that needed to be released, and he forgot to release the lock. And so it took off into the sky, and it could just keep climbing and climbing, but it could not level out until it lost air and then crashed. They dubbed the airplane too much airplane for one man to fly. And they therefore scuttled the plan to order the planes. This nearly bankrupted Boeing. They had a congressman, however. He demanded what we now call an earmark, and made the Army buy half a dozen of these planes just to keep Boeing afloat. So a year and a half, 2 years later, the plane arrives on a tarmac at some Army air base, and the pilots look at this thing and they say, "We can fly this thing. I'm sure we can fly this thing. I just don't want to die in this thing." So what did they do to solve this problem? This thing looked incredibly complex. Now, what I'm fascinated by is how they looked at this problem, because they didn't look at it the way we would do it in medicine. They did not make a 3-year fellowship in flying the Model 299 airplane. They did not make a pay-for-performance program. They made, well, I want to tell you a little bit before I jump into that, what they made. You know, what they were walking through in the aviation world is what I've come to think of as the stages in the improvement of performance under conditions of complexity. And what we do is we tell people in the primitive stage, you should do X. You should remember to unlock the elevator controls. And then we get it more advanced, right? We get to the medieval stage, and we go, you must do X. We have guidelines, we have standards, and the guidelines say you have to unlock the elevator controls. We issue regulations, we do pay-for-performance programs. But it doesn't solve the fundamental problem that this stuff is hard. And so what they created was a stupid checklist. This was not a recipe for how to fly a plane. This was not a guideline. When you read this as a professional, as a pilot, you know what it's talking about. The rest of us don't. But you see on here that the elevator controls are not going to be forgotten. And with this set of simple checks, they were able to fly this plane 1.8 million miles without a single mishap. And the result was that the Army ended up ordering 13,000 of these planes. It became one of the backbones of our military aviation superiority over Europe in World War II. What they had done was they'd gone to a third stage, what I'd call the modern stage, which is to recognize that you have to understand how to make it possible for X, whatever it is that's the good thing we're trying to do, becomes the norm. And that means figuring out how to make it simpler to achieve that. The simplest form of a system that allows you to have the norm is a checklist. You can get more complex. You can have default systems. You can have feedback loops that give you complex data showing you, your speedometer and how fast you are going or how slow you are going. And that's what they were doing. We had a project that we were asked to be involved with by the World Health Organization to try to reduce deaths in surgery globally. And we did what the World Health Organization does, which is convene lots of people to try to come up with the guidelines for what safe, successful surgical care looks like. It was 250 pages long, And when you go into the basement of the World Health Organization, passing between buildings, you end up and get lost a little bit. You will find the basement of the graveyard of guidelines, where there are pallet after pallets filled with shrink-wrapped copies of guidelines. And we did not want to be down there. And so the puzzle was, how do we go from being a guideline to being a norm? And so we asked Boeing's chief safety engineer to come with us to join our project. And what he helped us do was help make a checklist. Now, part of what he recognized was that there probably were places that were already making simple systems like this that were out there. And so we started canvassing around, asking our friends, talking to different people. And it turned out that there were a few places that had started to make checklists, and we more or less just cobbled together what they were doing. Kaiser Permanente in Southern California, Johns Hopkins, and as it turned out, Columbus Children's Hospital, now known as Nationwide Children's Hospital. These were the backbone. They had made a checklist to reduce infection at Nationwide Children's. Kaiser's had improved the ways that they were doing team communications, and Johns Hopkins had done the same, and we pulled it together, and there are a few basic ideas. One is recognizing where the leverage points are in a system. And so we made a little pause point before the patient went to sleep, before the patient had a skin incision, and one more pause before the patient left the room. We saw those as high leverage points. If we could get 60 seconds of attention, the team would be able to make sure that all of the key things that needed to happen at that point had actually happened. And that it might even not only save harm, it might save time. And so you had dumb checks like making sure you have the right patient in the first place on the table, making sure you have blood available if you needed it, making sure you have antibiotics given in the right time window. But the powerful parts were making sure you had a team that could handle the complexity of the job that they were handed. So make sure everybody on the team knows each other by name and role. Trying to maximize the chance that they are prepared for the unexpected by having the surgeon review very swiftly what are the critical or non-routine steps the team needs to be aware of. How long will the case take? What is the blood loss the team should be prepared for? The anesthetist, what are the patient medical history concerns? Nursing team, is there any sterility concerns, equipment issues? Do you have any questions before this incision is made? And then at the end, again, a little bit of planning. What is needed for the recovery of the patient? What needs to go into the orders? We tested this in 8 cities around the world. We deliberately picked an extraordinarily diverse range of environments, because what we thought was that systems likely don't work whether they're in Seattle or Toronto or London or rural Tanzania or New Delhi or Manila. And what we found was, indeed, in every hospital that we implemented the program, and we tested in 8,000 patients in a pre-post study, in every hospital they had a reduction in complications. The average reduction in complications was 35%. The average reduction in deaths was 47%. This was beyond what we thought was likely possible. It was then tested in further studies, including one in the Netherlands with a good control group, where they deployed a checklist-based approach. And again, eerily similar results. 47% reduction in death, 1/3 reduction in complications. It is now deployed, become standard of care around the world, and then people are innovating, they're improving, they're putting their own versions of what these can be and how to make them better. We know they're part of care in at least 4,000 hospitals around the world in a very practical, real way, as well as being the standards country by country. And so now the question is, could you apply these ideas more widely with a group of pediatricians and obstetricians and midwives, led by a pediatrician named Jonathan Spector, who helped us launch this in Boston. We started asking, how do you think of the system of just child delivery? And what we discovered when you got people together was there were huge numbers of guidelines. The World Health Organization alone had 11 sets of different guidelines around the different parts related to childbirth. You had pediatricians saying, here's what we need to do to make babies breathe. Obstetricians saying, here's what we need to do to help with hemorrhage, but nobody talking together and thinking about it from the practitioner's point of view. How are we supposed to put all this together? How are we supposed to get all of these demands done? And so we crammed everybody in the room around this fundamental burden, this triple burden of child mortality and maternal mortality. This key moment in care that everybody's trying to change, and asked, how do we prioritize? And we saw that the moments of greatest risk between preconception to the neonatal period were at the moments of a few pause points, when a mother comes in labor, when she starts to push, what happens to the mother and baby immediately after birth, and what happens before they're discharged home. And we designed a checklist to tackle the big killers, to bring together what were already in the guidelines but just needed to be turned into something that was usable. And so a way that when the mother comes in, she's checked about referral criteria for both the mother and the child to be born, that you have key equipment available for the resuscitation of the baby and to deal with bleeding, and so on. At each of the 4 pause points, the key things that could happen, and we tested it in 17 hospitals in 10 cities around the world, just for the question of, could they use it? Was it usable? And they made huge changes and helped us make it streamlined and more streamlined and actually make it practical. And then we rolled it out in a pilot study in southern India, in a town in the state of Karnataka. And we picked India because it has some of the highest child mortality rates in the world, a place where the neonatal mortality rate is 40 per 1,000. This is 20 times what's our normal neonatal mortality rate. India has a quarter of all the deaths in childbirth in the world. A stillbirth rate of 20 per 1,000. You're talking about 6% of child deliveries where the mothers come in labor and end up with a stillbirth or a child who dies within 7 days. And what we did was we brought this system out by simply teaching a small team at that hospital how to teach the others. Because if this is to be a scalable idea, others have to be able to teach it. And so we helped them learn how to teach it and present it to their own colleagues, make changes as they saw what they needed to make it work. Before the study, the average childbirth got only 10 of 29 essential practices. And after a 1-week training program and deploying it and then following it over 3 months where we watched the care 24 hours a day with people who observed what actually happened, it was 25 out of 29 practices. It's a fascinating thing. You ask them, do you wash your hands and put on gloves? Of course we do this. But then you watch, and it was just 1% at baseline. And it could be 98% before we were done. You ask, were you offering breastfeeding? Yes, of course we offer breastfeeding and do skin-to-skin warming. But then there's the reality, and if you don't check, if you don't make it part of the habit, if it isn't the norm, if it's just the guideline, it doesn't happen. And they were able to reach 91%. Giving oxytocin within a minute after birth to reduce bleeding is a fascinating question because when we surveyed, they didn't have the oxytocin regularly available. We didn't put money in or supplies in, but when we brought the checklist in, we helped them understand this is not just about the nurses at the front line. This is also about the people who oversaw the hospital, and understanding that the items on this list are among the most important items that have to be there all the time. And in the space of time that we did the study, they were able to reach 70% performance along this metric. We're now testing whether this is a truly scalable idea. Can you make a system like this work at large scale? And can you make it work in a place like northern India, which has the vast majority of the deaths that occur among some of the poorest populations in the world? It's a complex program. It has involved incredible partnerships with the World Health Organization, Gates Foundation, our laboratory called Ariadne Labs at the Brigham and Women's Hospital and Harvard School of Public Health, Population Services International, a community empowerment laboratory in Lucknow, a medical college in Karnataka. But the idea is simple. Can you introduce this small version of a system in 60 facilities where the neonatal mortality rate and stillbirth rate are actually even higher than 6%? And can you measure whether you've made an impact and harm in a randomized trial with 60 controls? It's again around the concept of asking, how do you make systems that support your ability to do what you do in your clinics every day or in their hospitals every day? And we stole an idea from another system, and this time not aviation, this time farming. And when our hometown in Athens County, Ohio, you ask, how do they know how to improve farming in our county? They have extension agents who bring the latest knowledge to farmers one-on-one. They go out and see people on the farms. And they bring them tools to make it incredibly easier for the farmers to fight, whether it is infestations or bring in new capabilities that are transforming their world with genetics and other kinds of fields just as much as they're transforming ours. And so we created an extension worker. We're calling them childbirth improvement workers, who go to the hospitals, know the people involved, and simply have a cadre of places that belong to them that they work to improve. We've focused them in 6 regions of a vast country. This is 190 million people in this one state alone. If this state was a country, it would be the 5th largest country in the world. But when you think about how do you help the people at the front line cope with their complexity, instead of just demand that they do it, you come to think of it in a different way. We don't know whether we will change these outcomes yet. We're going to be a good 2 years away from being able to know those final results. We're still just scaling up. We're only in 5 of those hospitals, and it has to scale up to 120. It's like scaling up in 2 states in the United States. But the concepts have already begun to embed and teach us something about the kinds of needs we have. When you work elsewhere, you begin to see your own system in different ways. What you see in hospitals in low-income countries that are transitioning to become middle-income countries is that the first thing they do is they build hospitals. Their healthcare system is hospitals, and they fill with people who have basic needs. You look carefully at this picture of a ward near the village where my father grew up, and what do you see? You start seeing that there's actually 2 people in this bed, that they're so filled with ordinary problems and people who are waiting for care. This is the children's and women's ward, and this is a woman with peptic ulcer disease that has become so severe that she has bled. And a young boy whose problem could be anything from a new diagnosis of diabetes to what it turned out to be in this case, imperforate anus, in which he had managed to get a colostomy, which allowed him to live and eat, but now he wanted to be able to get rid of it. It's so packed that children stay on the floor with the families. And here's a child who'd been there a week with drainage of a simple abscess. What you start to see are the need for primary systems that can work. And it is like the sharp point of this world of the 20th century being brought into the 21st, where you think you're overwhelmed by all of that knowledge that you're gaining from a conference like this. And you can imagine how they feel, how a doctor feels in that world. But one of the mistakes that's happening in the world is that those places are doing what we did, and they're building and building and building hospitals, but nothing around the hospital to be able to make that difference. And if you want a future that looks like the one we have, where primary care that could do a much better job of these problems is weakened and disempowered and under-resourced, and the hospitals filled with specialists is where people go. This hospital's full, and this government is going to tell the world we need more hospitals, when what they need is primary care. There's fundamental ideas underlying how you make primary care work, but we're only wrapping our minds around it now. And this is where I see you, who are working at that front end, being able to make a difference. Barbara Starfield at Johns Hopkins, who thought long and hard about these problems, classified 4 basic things that you do in an office that works. You provide contact for people, first contact access. You provide connection. You help them with a referral network so they have somewhere to go other than an emergency room when they have a problem if you can't deal with it. You offer continuity, and you offer comprehensiveness, a sense of being able to take care of this wide range of problems. We've never made those systems for those basic ideas work incredibly well. We've never made it so that we could handle the full flow of discovery and offer this capability to people. And you guys are the experimenters at the front line who are making it work. We did a study in an ambulatory clinic down the street from me, from our hospital, at a place called Harvard Vanguard Medical Center in Kenmore Square, right outside Fenway Park. 2-2, World Series, we're doing okay. And one of the questions we ask is, at an ambulatory specialty clinic, took care of, has pediatricians, has surgeons, has cardiologists. Out of those 13,600 diagnoses, all kinds of rare conditions, how many of them actually come in the door in any given year? And the answer was 6,000. 6,000. And then we said, well, how many does the average practitioner take care of? So the pediatricians, 300 in a year. New diagnoses that they had to take care of that were new to them that year. The problem list had more than 500 different kinds of problems. The management of variation is what we do. And the management of this range of needs is the capability we have. What we had last century was the discovery of the power of reductionism. It was the century of the molecule. We discovered how powerful the gene was, how powerful the neuron was in the brain. And we discovered the power that comes from subspecializing, with carving up our work into smaller and smaller bits. But we've entered a century where we now are in, I would call it the century of the system, because we're realizing it's how they all connect that makes the ultimate difference, how they cooperate, how they become a whole. And so gene networks are turning out to be incredibly powerful, and you heard about the concept of epigenetics earlier, and that's simply what we're talking about. How do the genes interact in ways that make a difference? Neurons don't become behavior until they network to become the brain and create consciousness. And in the same way, with all of our components of care, they don't become health. They don't become wellness till the pieces fit together, whether it's for a child who might have a new diagnosis of diabetes, a mother with peptic ulcer disease that could be solved with some basic kinds of care, or the most complex kinds of care that we're trying to provide for patients with severe asthma, cystic fibrosis, and onward. What I want you to understand, and what I want to finish with, is that we've spent too long expecting that Washington could solve this problem, or that insurers would solve these problems, that they would offer us computer systems that made our lives easier and reimbursement systems that will work. And they couldn't possibly, because they don't know what it's like to do what you do. No one is going to solve this for us, making it so we can handle 400 people, 400 different kinds of problems coming in the door, so that we can manage that range of things that you just learned about today. It will require teams. It will require cooperation. It will require experimentation. And that's the excitement of this next decade in medicine. It is the century of the system, but it's the discovery of systems that work. It will start as simple as little checklists, but it'll become much more interesting, much more complex, with groups of people being able to work together and make entire populations around us healthy. I thank you for all you're doing to make this possible, for the ways in which you're making not just children healthy, but this whole country. Thank you. Thank you. Thank you.